Hello, everyone, and welcome to another Unfiltered production. Today we have Dr. Jason Falvey of University of Maryland and Cindy Kraft, my esteemed business partner. And those of you that follow our newsletter and follow our emails know that I'm pretty passionate about this subject, and I kind of share that passion with Dr. Falvey about the role of big data in home health. A lot of folks are using data to decide how they provide care. I'm kind of teeing you up, Dr. Falvey. Thoughts?
Yeah, I mean, so as you know, I'm a clinician that has a lot of epidemiology and health services research training. I work with big data as the primary mechanism for several of my, federally funded grants. So I will say that big data is an incredible tool if we use it well. And it's collected well, and it measures what we think we're measuring, and we interpret it with a clinical lens. And I think so often that the data that we rely on to make clinical decisions is either collected with a completely different purpose than we're using it for, or has notable gaps, like we're missing key pieces of clinical information or key vulnerabilities that that cause a bias, right? We think that we're measuring everything at a home health agency level, but there's really a lot going on prior to that hospitalization that we need to take into account. And then some of it is just interpretation. Like we nurses, physicians, and epidemiologists see the same data, the same results, and we have completely different conclusions about it. And so I think there's a lot to be said for doing it well, and I don't think that's exactly what we're doing quite yet.
And the concern I have, Jason, is that agencies are taking the recommendations that they're getting from their big data companies, and they're using it to prescriptively provide the amount of care that they're suggesting. And I have said from day one, that's all pointing to profit. It's all pointing to profit and loss, the plus and minus. It's not pointing to the necessary care that a patient needs. Cindy was approached at a national conference recently, and someone asked her, how can I have therapy visits without ruining my outcomes?
Wow.
And yeah, that was kind of a scary moment, because I think a lot of the big data is pointing towards less therapy now that it's not a financial incentive to provide it. And we're in a confusing point, but having seen the number of data companies that are proliferating home health right now, where do you see that it doesn't match what's needed in home health?
Yeah, so there's a lot, like I said, there's a lot to unpack there, but I'll start with the limitation of these data companies overall is that they don't have all of the relevant clinical information. If you're taking information that's only collected at OASIS, which is a very rich tool, but it doesn't include key pieces of information at the hospital level. And the example I give all the time is, did that patient receive intensive care unit stay? Yes or no? That is nowhere to be found on the OASIS. Critical illness, we know, is a major contributor to disability, to decreased recovery, to mental illness burdens, PTSD, psychological distress. We think about somebody who's mechanically ventilated for 10 days in the ICU, or we have somebody who is hospitalized for 10 days with pneumonia, and they go to home care, and they both come in with respiratory distress or COPD as their presenting home care diagnosis. I'm going to guarantee you that the person that was in the ICU has a much worse prognosis, even if they look similar on the OASIS coming in, right? They have a limited trajectory. They had delirium in the hospital. You don't know. You have no idea. You don't have that information ahead of you. What were they doing before the hospitalization? And we have research going on now that says people that were spending, a declining number of days at home before their hospital stay were 65% more likely to die in the next year. And they spent substantially fewer days at home. So they were more vulnerable to readmissions and having multiple hospital stays. All of that information is generally missing from these kinds of data repositories that collect only information from home care. So that's concerning, right? You're missing key pieces of clinical information. And at the end of the day, you're second guessing your clinicians who have that information in front of them, and they might be saying, this person is really vulnerable. I know the research, I know the literature. And you're predicting 6 visits, but you know that this patient's probably going to need 10 or 12, right? And why would you second guess a clinician with basically a souped up version of Chat GPT that's using data that's collected not for the purpose of prognosticating healthcare utilization?
And that's something
I
that's
was gonna
pretty,
jump.
go ahead, Cindy.
No, I'm just going to jump there because I mean, my mantra, I'm gonna probably end up with it on my tombstone, is Oasis is discipline neutral data collection. It's merely snapshot pieces of information, and it's used and intended to measure an outcome in very specific ways. And for that to get hijacked, first of all, it got hijacked to become payment. The original developers way back in the old days, this had nothing to do with reimbursement, and that got added, which messed with it. But now it just seems a gross extension of those two ideas to now say, I'm going to use it to predict something, while it also has potentially financial implications and items that were never intended to be used for either one.
Yeah, and I know the person who did a lot of work on some of the original Oasis, and I worked closely with him, and he gave me some of the initial code to start analyzing home care data. But I can tell you, he was not a clinician, and the decisions that he was making were certainly much more statistical. Hey, is this model well calibrated? Again, that was his job, right? He did a great job at his job, which was not to provide clinical tools to predict healthcare utilization. It was to give Medicare some sense of an outcome that they could go from. And these tools have evolved over time, but they're not keeping up with the literature in terms of what's the best way to measure function, the best way to measure risk. And the needs of patients and unmet needs for rehabilitation are not well captured on Oasis.
And one of the things that we're seeing from CMS when they put out the proposed rules, and the hospice proposed rule just dropped day before yesterday, is that we're seeing that these behavioral adjustment, quote unquote, is coming up. To me, it makes it low-hanging fruit. If you're using a data collection or a data mining company to decide how to provide your care over time will become homogenous. It will become the same. And CMS can see that very clearly in our industry, and they're making changes to the reimbursement due to that. Jason, what do you see as the future of these types of data mining companies in home health, and not only that, but the risks that they pose to agencies if they're used wrong?
Yeah, I mean, I think homogenous is the right word, right? This is, the technical word regression to the mean, right? All we're going to do is condense it down. And by curtailing PT use universally, Medicare is going to look at that and say, oh, well, you just don't need that much PT. And it gives further incentives to decrease the weight of episodes that PT is involved in, right? Which is counter to the kinds of things we should be measuring. We're also anchoring the system to outcomes that are potentially gamed or heavily coached by agencies, right? In terms of functional outcomes on the Oasis are something the agency controls because they teach people how to do the initial and the discharge assessments. You guys probably know that teaching maybe isn't as good as it should be, but they do teach, and there is some, there's some opportunity for manipulation. I'm certainly not going to accuse a company, but I would say that there is a lot of movement of that data to certain directions. I would say the work that I'm starting to do is looking what happens after that person leaves home care. And what we've done at the hospital level, and we're going to move into home care agencies, is look at days people are spending at home after they're discharged, which the hospital can do nothing about afterwards. They can't game the system. They can't manipulate that. And we follow people for a year, and we can tell differences between good quality hospitals and bad quality hospitals based on how well they get people to age in place afterwards. And they're not the same hospitals that are good at reducing mortality. And they're not the same hospitals that are, good at reducing readmissions some of the time, right? There's some flip around. So there are agencies that are probably really good at managing patients that we're getting masked because we're measuring the wrong things.
That is incredible.
Well,
and I have a question, and Cindy, I'm going to let you go first because I think my question could be a little bit controversial. So go ahead, Cindy.
No, I was just going to interject. I think the challenge of big data or using predictive data in this way is there isn't anything really wrong with data making suggestions or identifying options. or giving me ideas. But where I get concerned is data in inexperienced hands or not necessarily well-informed hands makes me think of what my dad always used to say, figures lie and liars figure, in that you can make it go certain ways if you are inclined, or you can totally innocently think that this predictive thing is the gold standard, this is best practice, and that I'm supposed to go do it this way because that's what the data told me. I think data requires a level of knowledge to interpret that. Like you said, picking an OASIS item, you can put down, there is information that the patient was coming from the hospital. Now, were they in intensive care or not? That's a next generation conversation that says, all right, do we practice differently for those that did come from that than the other? But knowing how many of my patients come from the hospital is a place to start that and then be able to dig deeper. I just get concerned when it's like, because I got this report. And this is why, K&K gets asked about, reports and data, and do you put big picture thing? And I always remind people that whenever you go to that source, you have to remember that they're pulling from their clients. They're pulling from the data they have. You always have to be careful when you start blanketing it with Medicare this or Medicare that, when you only have one piece of the puzzle. And that's what I wanted to circle back to what you said earlier, when, as a researcher, you have access to the whole. Prior to home health, all of home health, not just, a subgroup that used Jason Falvey's home health agency. You're seeing all of it. And then what happens after? I think far too often we're thinking that this is what it's going to, they're telling me what to do. And this has to do with benchmarks. This has to do with lots of different things, or scrubbers. It's like, yes, but you're basing your data on your client base. And that's great. Just everybody has to understand that, so you utilize it accordingly. And that's where, we're not saying that the data is bad or these companies are bad, but we have to make sure as the user, we understand what we're looking at, what it means and what it doesn't mean. And if I stand out as an outlier that now says, well, everybody else is doing 10 therapy visits and I'm doing 23, that's worth a conversation. Not to say, oh gosh, we now want to do 10 because everybody else does 10. No, that's called average for a reason. My goal is not to become average. But if I stick out, let's figure out what this is and make sure that this is on the right track. And I think we see that also briefly when folks get into issues with their charts being pulled. They have too many that look just over a lupa. They have ones that look higher, and people react with, that means I shouldn't have any of that. No, that means you should look at it and say, if I have clearly defensible clinical reasoning here, fine, I'm not normal, but it's okay. But what Sherry and I see is, oh my gosh, it doesn't align with this thing I saw. So now we have to change our practice to look like that, and not asking enough, where did the data come from? What is the pool of people involved? Just to make intelligent decisions and not knee-jerk reactions to the latest number that showed up in an article.
Yeah, and so I think your agency is going to know best the kind of patients you're drawing from. Are you getting disproportionately patients with really complex? Are you known as like the fixer home health agency? Mine in Wyoming certainly was like, we were like second chances university. You failed home care the first time, or you didn't do well, and you came to my school, and that was your last chance before nursing home admission. Was kind of like how I was viewed. Right. And we had a pretty good success rate at working with the most complex people that kind of got blown off by the other ones. But I would describe us as a positive deviant, right? Because our utilization was higher for rehab. I had a couple of patients on my caseload for more than a year with ALS or neurodegenerative diseases. But you know why I never got audited and never had any problems? Because I document really, really well with really good outcome tools and justify that need and that ongoing need for skilled therapy. So you can be a positive deviant. Just because you're outside the average, that's not a negative thing. Positive deviants are what I study. So part of my research is I'm like, who's exceptional? Who's the top 10% of agencies and what do they do? And I don't look at things like costs. I don't care about money. I don't even look at things that the agency does themselves and controls. What are the top 10% of agencies at stuff that they can't control the measurement of? Like days spent at home after that person leaves. You successfully discharge somebody to the community. Do they actually stay there? Are you keeping them there? Same complexity of patient, Do we also think about neighborhood environment? If you're in a lower income, lower resource area, maybe you're drawing patients, or maybe you're the only agency that serves a really vulnerable neighborhood, right? So documenting the neighborhood environment and some of the additional challenges, the home environment challenges that we have. I ran data the other day, and I'll have to share it with you guys, about like the home conditions, the percentage of home conditions that were like incredibly bad, with like rodents or broken holes in the floor and things. I have national data on people that received home-based therapy and like what their home environment looked like, which is data no one else will have. And it's a high percentage, much higher than we would have thought, in terms of the environmental challenges we're dealing with. So if you're dealing disproportionately with lower income populations, or more socially challenged populations, with more social determinants of health that don't get reflected well on your OASIS, your agency should embrace being a positive deviant and not try to go to the mean.
So Jason, I want to thank you for your time, and I want to thank you for the term positive deviant. I like that term. In many ways, I might use it in my life in many other
No.
But thank you for your opportunity to talk a little bit about how this data is being used and possibly misused. And we just want to bring truth to our listeners and to our subscribers. We want them to know that we're not back. This is not opinion. We're not bringing people to you that have opinions. This is stuff that's backed up in data and backed up in studies. And if you have the opportunity, follow Dr. Jason Falvey. He's on many of the socials, and oftentimes we'll post his research, and it's super interesting. And that's the kind of stuff that can make a very well-rounded home health program even better. Serving those folks and keeping them at home, which is what I'm passionate about. And Jason, I think the agency that I owned in Florida was also a second chance agency. I remember asking my referral sources, please give us a few easy ones. We have to be able to, do better with a few easy ones. And this is not negating the need to be able to make a little bit of a profit to keep the lights on, but it's about, home health being the place of choice. The people want to stay home. They want to be able to thrive at home and have a high quality of life. So again, I want to thank you so much for the work that you do.
Yeah, well, thanks again for having me on. I always love talking nerdy with big data, and I'm hoping we'll have a chance to put a couple of things out with my collaborators at Cornell and other places doing home care work with other disciplines, and bring it all together back to you guys here soon.
Thanks, Jason. Thanks everyone for listening. Be safe.